Good morning, everyone. Thank you for joining the first of our monthly series of webinar debates. This is a new venture for Respiratory Futures, and it's also the first time that I've done this, so let's keep our fingers crossed. Over time, we're going to build a program that discusses quite a wide range of topics, and we'll increase the number of ways that you can participate in these sessions. But for the first session here, I'm going to just try and explain as best I can what I think is the interpretation of the clinical commissioning landscape in England for respiratory disease. And I've entitled this "The Future is Local" for reasons that will become evident as we go along. So we'll get started, and then there's an opportunity for you to post questions as we go along, and I'll try and answer them at the end of the talk. So I don't know what that was, but the first slide here, I'm just going to remind people about how the National Health Service in England works, because it's different from other health services in the UK. In Wales, in Scotland and Northern Ireland, they have a publicly funded health service, which is also publicly provided. But in England, although the health service is publicly funded, there is increasing marketisation in a drive to improve efficiency. The feature that all health services in the UK share is that the patient only gets to a specialist through the referral of a general practitioner. This is not the case in other countries in Europe, though it is the case in some. Now, there are principles associated with our National Health Service, and the first is that it's funded through general taxation. It's free at the point of need, and in England we have a mixed economy of providers, but all these providers must adhere to some principles, and the principles are around choice for the patient, about the best possible quality, about safe services, about transparency of outcomes, being able to understand how providers do, and also about providing value for money for the services. So these are the principles under which NHS England and other commissioners operate. Now, one of the problems that we clearly have in England is this position of constant change. We're always trying to catch up with the latest change in our health service arrangements, and the last few years have been particularly frantic. You remember that it's only a couple of years ago that the Parliament passed the Health and Social Care Bill, which allowed for the constitution of NHS England as the main commissioner. Now, NHS England was only in place for 1 year when the chief executive changed, and in October last year, the new chief executive, Simon Stevens, produced his 5-year forward view, which does indicate even a change in the commissioning direction and a review of the structure of NHS England itself. Alongside that, other arm's length bodies like NHS Improving Quality and Public Health England and HQIP and NICE and all those are also going under review. And things within NHS England, like the strategic clinical networks and clinical senates, are being examined at the moment to see whether they're fit for purpose. Now, some things will change, but also in 2015 we have a general election coming, and who knows what the landscape will look like after that. But we are where we are, and we're going to try and work our way through to see how we can best commission respiratory services in the current climate. Now, as National Clinical Director for Respiratory Diseases, I have responsibility for a number of different conditions, and the main ones are shown on the slide here. But I'm going to concentrate on COPD because it is by far and away the largest condition that we have to consider in terms of burden. Now, to commissioners, you can ask the question as to why COPD is important. Well, for commissioners, it's obviously a common long-term disabling condition. It's one of the top 5 causes of premature mortality. It's a frequent cause of hospital, perhaps one of the most frequent causes of hospital admissions. At the same time, many cases are undiagnosed in primary care, and there are large variations in care around the country that account for considerable avoidable mortality. We've also got treatments which we know work, like rehabilitation and self-management, but there's no capacity or little capacity to employ them. And we also know that if we do the right thing around integrated and anticipatory care, it is also cost effective. So these things should be happening, but for a variety of reasons they're not happening in the way that we would like. In terms of the background for respiratory disease, the mortality figures are quite interesting. If you look at potential years of life lost over the last 3 or 4 decades, we find that things like heart disease and cancer and stroke are actually coming down, but respiratory deaths are staying stable or perhaps increasing. What's more to the point is actually some of this is natural decline, and the introduction of national service frameworks and networks, strategic clinical networks around 15 years ago, have just continued this improvement. What I think would be interesting about respiratory deaths is if you took lung cancer out of the cancers and put it in respiratory deaths would be in the middle of the pack there, along with the other conditions that have strategic priorities. And this is a problem for us because, as I pointed out before, respiratory disease is not part of a strategic clinical network and therefore does not have the infrastructure or the national infrastructure support to improve commissioning. So the strategic clinical networks include cancer and cardiovascular disease, maternity and children, and mental health, dementia and neurological conditions, but there is no room there for national support for commissioning of respiratory disease. So the commissioning of respiratory disease is primarily a CCG responsibility, and the care is delivered by primary care and acute trusts. There is some direct commissioning through the specialised commissioning process, but this is around rare things like transplantation or volume reduction surgery and home ventilation. So for the majority of patients with COPD, it will be the 211 clinical commissioning groups that determine the provision of care. So if we try and influence the system, I mean, the first difficulty, of course, is to understand how the system works. And I'm not sure that even people who work in it have a clear idea of how it works. But there are a number of ways of influencing the current system. As I pointed out, the first one is that obviously the focus of attention has got to be around the CCGs, around local influence, because there's no national priority for the diseases themselves. There are, however, some thematic priorities within NHS England around things like early diagnosis or integrated care or parity of esteem, where you can draw on those resources to help with respiratory conditions. There are also things called programme boards, which have a budget and have some influence around themes like rehabilitation or diagnostics, where clearly they are relevant to respiratory disease and can be influenced in that way. But within the system itself, there are a number of quality and financial levers or incentives, and I'm sure many of you will know about things like Sequins, which are negotiations with local CCGs to improve quality, QOF, which is set to improve the quality of general practice by recording information, and best practice tariffs, which reward particular areas of care by increasing the tariff. You can also influence the system through instructions from other arm's length bodies like NICE or NHSIQ or Public Health England, where they can exert an influence on the commissioners. Local networks too, as I'll demonstrate later, have a catalytic approach, have a catalytic benefit to local commissioners, and so do patient organisations and professional societies and colleges, though perhaps less so than some of the other levers. So what are the current key targets and organisational agendas which are important to address for improving respiratory care? Well, we have an important job to do around public and political awareness. We clearly have an important job to do around early diagnosis and also improving the care of long-term conditions and acute care. Now, the sort of areas that we can tap into in terms of improving these things are around developing integrated care structures, population commission level commissioning, which includes year of care commissioning, commissioning for value, and taking into account increasing individualisation of care around personal healthcare budgets. And I'm going to touch on some of these just later. The first thing is about awareness, and one of the problems with insidious onset of respiratory disease is that breathlessness is something that people sort of get used to. It's not like the abrupt onset of chest pain or stroke. And so people are not aware of the development of COPD often. So the Department of Health is currently funding a breathlessness symptom campaign to make sure that people who are developing inappropriate breathlessness bring this to the attention of their doctor earlier rather than later. And this is currently in a sort of rollout phase. It's undergone 2 successful pilots in the north of England and is now undergoing a regional pilot in the east of England. Hopefully this will have an effect on bringing people forward to their doctors when they have early disease. But inaccurate or delayed diagnosis is a major issue for COPD. The surveys estimate that we have nearly 3.7 million sufferers or people with airway obstruction in the country, but only a fraction of those are diagnosed. Other statistics also look bad, that most patients with COPD, when they're ultimately diagnosed, have had a missed opportunity to make that diagnosis up to 20 years prior to when the penny drops. And also, patients are still being admitted to hospital, having never had the diagnosis made. And you would think that perhaps of the undiagnosed patients, that most of them will be in the mild or moderate category and not expressing symptoms. But actually, that's not entirely true. The surveys would demonstrate that even people with severe or very severe airway obstruction remain undiagnosed. So how do you get a simple diagnostic test like spirometry into practice? Well, the cough is the obvious incentive to encourage spirometry. But the problem with the cough is, well, there are several problems with the cough, which is why it's being reviewed. But one is that you only do spirometry on people who are known to have COPD, which isn't on the whole terribly helpful, particularly if you're trying to find new cases. The other thing about cough, of course, the criticism would be that it simply measures something without necessarily encouraging people to do anything about it. So how do you go about improving case finding? Well, I think one way of doing this would be to use GP dashboard software, something like Grasp COPD, which can show the practice how they're doing in terms of their expected or actual prevalence of COPD, and also how they're doing in terms of the management of the patients they've already got. But software like this is able to identify patients that might have COPD and therefore could be brought up for spirometry. Now, one of the major problems that we have with COPD for commissioning is that it is one of the conditions par excellence where it's associated with multiple long-term conditions or multi-morbidity. This is some data from the South Somerset Symphony project, which just catalogued a number of long-term conditions with different index conditions. So, for example, if you have asthma, only 50% of people might have an additional long-term condition, but 50% will just have asthma alone. If you take COPD as the index condition, over 90% of patients with COPD will have some other comorbidity. In fact, they're more likely to die from something else than they are from the COPD. And 50% of them will have more than 3 long-term conditions. Now, this makes them very important patients, because if you have more than 3 long-term conditions, then the cost of looking after patients with multiple long-term conditions just increases almost exponentially. So they become very expensive patients. There may not be that many of them, but they are a burden on your health economy. The other thing to take account of is that as patients develop increasing numbers of long-term conditions, they also are associated with a larger number of mental health conditions or mental health impacts. So mental health is an important component of people with more than one long-term condition, and clearly COPD would be a substantial mental health issue in addition. Now, a modern approach to commissioning is going to be more person-centred. And when NHS England sort of started to develop its philosophies, it looked to surveys of patients about long-term conditions carried out by National Voices. And for people with long-term conditions, their view was that they should be involved in their treatment. That is, that their care is planned with people who work together to understand the patient and put the patient in control to coordinate and deliver services, which is not something which happens particularly well at the moment. And there are a number of components to this, this approach, which include discussing goals and communication with patients, making sure they participate in decision making, but also having a secure care planning process with transitions between specialists and a way of dealing with emergencies. Now, the conceptual approach to this that's been developed by Martin McShane is around the house of care. And many of you will recognize this as a development of the chronic care model, where you have a patient in the middle of things with an informed an educated patient and carer, and a healthcare professional who's prepared to undergo a dialogue with the patient. At the roof there you have an organisational process which includes care plans, guidelines and the like to guide care. But what's different about this is that at the bottom you have an evolving commissioning process which takes account of this and learns from experience how to improve the process of person-centered or individualized care. Now, it's probably worth stopping at the moment and just considering a few definitions, and these are my definitions. They're simplistic, but they sort of set the scene for the structure of the healthcare organization that can deliver such a long-term condition approach. Self-care is what patients do all the time. Action plans are written instructions and medication for self-management of exacerbations alone. They're not self-management. Self-management training is providing the patient with the necessary skills, knowledge and confidence to self-manage their whole condition. And pulmonary rehabilitation is a structured opportunity to provide the self-management training and the behaviour change that's required. But the commissioning framework is around integrated care, which is necessary for the delivery of perhaps all of these things. Now, we can go so far with integrated care, and in the latest King's Fund report on specialists in out-of-hospital settings, there's a description of some worthy cases, and one of them is the Whittington Respiratory Service. And what the Whittington Respiratory Service here is that it's working within an integrated acute and community trust, which does make life a bit easier. But they have enforced a clinical leadership across the whole spectrum into the community. They've taken advantage of commissioning incentives like in locally enhanced services and sequins. They've focused on education, and they've made all these components of care join up. Now, this is probably about as far as you can get with the current commissioning structure, and obviously many trusts and community services don't have this degree of linkage. So in October last year, Simon Stevens produced the 5-year forward view, which has addressed many of the problems that beset the health service at the moment. This is a politically astute move before the general election in a few months' time, and he did come up with a realistic financial analysis which requires an above-inflation investment in the health service and considerable cost savings to be sure that we can retain the health service that we want. But he also changes the focus to prevention within healthcare and treatment as opposed to prevention from the public health perspective, and focus on multimorbidity, which I've outlined before. He also thinks that people should have more individual responsibility for their healthcare budgets, and seeks the removal of what are primary and secondary care barriers, because we have had a hierarchical health structure up until now. There'll be less direct commissioning from NHS England. There'll be mixed models of provision and a focus on local prioritisation. Now, this 5-year forward view, which was a policy paper, has now moved into the forward view into action, or the development phase, particularly around new models of care. And the way this is going is that there will clearly be greater devolution to local commissioners about how they go about things. There'll be much more co-commissioning and less direct or specialised commissioning, and there'll be maximisation of local planning with the encouragement to develop the new models of care. These won't be top-down models of care. These will be people in local communities just developing a way of providing their commissioning structures in a way that fits the principles. He also indicated that we'll be revitalising small hospitals again, getting serious about prevention and empowering patients, perhaps with personal health budgets, and there'll be a focus on success rather than failure, which is something that we've rewarded in the past. So if you don't do very well, you get more money, and that's not really good philosophy. What's clear is that there will have to be greater efficiency in the system to make all this work. Now, one of his points is about barriers of access of specialist care, and at the moment we have this system where we've got primary care with the general practitioner, and the specialist care is confined within acute trusts, and the GP can choose or not to refer to specialist care and may or may not do so. Now, this isn't a very good state of affairs because the patient has no access to specialist care unless the GP refers the patient. And so the new commissioning models suggest that this is much more joined up. And the two commissioning models that are mentioned in the 5-year forward view are like stalagmites and stalactites. There's the multi-community provider model where a primary care health centre perhaps might enlarge to include other professionals and to draw in community services under its wing until it finally includes specialist care within the community provider. The other possible approach is a vertical integration where acute trusts take over primary and community services so they reach down to the very first contact with the patient, and this is the primary and acute care systems. But there may be other commissioning models which achieve vertical integration in a different way. Now, one of the grumbles about the failure to do this in the past has been around the supposed professional resistance, but I don't think this has ever been a factor, and certainly within respiratory medicine, the British Thoracic Society has been very clear about its willingness to develop integrated care models and community respiratory physicians to catalyze this process. What has stopped it happening have been the barriers set up by your employer, the acute trusts, who are possibly looking in the opposite direction, and the fragmentation of community services who are often not interested in either long-term relationships with consultants or making use of them. Now, just to remind you at this point, that before I move on to another topic, that you may want to input questions while I'm speaking so that we don't wait for the end. Now, I'm going to finish off by talking about value. Now, we've had some experience of this in respiratory medicine through this wonderful value pyramid that was produced by the IMPRESS reports. And value in healthcare is about the health outcomes that you get divided by the cost of delivering the outcomes. And we've had this exploration of individual treatments, identifying those like flu immunization, which offer most value for money, if you like, in treating patients. But I want to take this one step further and just describe to you this philosophy about commissioning for value. And commissioning for value is a project which is shared with NHS England, Public Health England and Right Care about identifying value opportunities in clinical programs or care pathways. And it does so by looking at the data and then offering individual CCGs analysis of that data and looking to a way forward to improve those services. So the commissioning for value applies to each CCG, and each CCG has been given a pack to identify from the data which is broadly available as to how it might improve its practice. And I take here Leicester City CCG as an example because I'm familiar with it. And the pack that comes from commissioning for value for them points out areas in their commissioning structure where they can improve things and get better value. And if you look at it down here, respiratory system problems is one of the top 5 things that they have identified that they can improve, and they provide data to support that. So if each CCG receives one of these packs and it looks on these metrics here and it finds it in the red there, which means that it's bad, that they have low expected prevalence of COPD, they're not measuring sufficient spirometry, they're not measuring sufficient FEV1s in their COPD patients, they're not reviewing them, and they've got a high level of unnecessary, perhaps, acute admissions. So these CCGs are encouraged to take note of this and work around trying to improve the value of the care that they offer. Now, this is to their advantage, and as I say, every CCG will have received one of these, and many of them will have respiratory system problems on it. So as a case example, which is cited on the Right Care site, there's Hardwick CCG in Derbyshire, which had a problem. It had the usual things: high undiagnosed COPD population, above average COPD spend, high admission rate, and poor audit results on the BTS audit. So the process there was that they took advantage of this right care methodology. They received what's called a deep dive pack, which is a more detailed bunch of statistics for them to work on. They engaged their stakeholders and they redesigned their care pathways. And within a few months' time, they had a 30% reduction in admissions, and they'd exceeded their QIP target by 164,000. So it does look as if this focus can work. Now, I want to finish just by looking at a couple of other things, and the first one is about population level commissioning. If we do truly develop, and the hope is that we will develop, vertical integration of services, that is that the commissioning organisation could potentially own the whole pathway of care from primary care up until acute care and beyond, then you can look at population level commissioning. An example of this is what's called year of care commissioning, where you set the scene for the whole population, but you need to stratify your population according to several things like risk or service provision or need, and you have to have a capitated budget that can split that that can follow that stratification into the various provider pots. So, for example, if you have a high complex cases with a large number of comorbidities, they might require hospital supervision only, but there might be just a couple of thousand of those, so you capitate your budget accordingly and provide the provider with that budget. Now, there are 4 pilot sites around the country doing this at the moment, and it's difficult with a fragmented service, and it will be a lot easier if we do achieve genuine vertical integration. Now, the last thing that I want to focus on is really the nub of the talk, really. It's around the future is local, because although we don't have a strategic clinical network, there are a number of local respiratory networks which have set up around the country, and they are a real catalyst for change, because stakeholder networks can work with CCGs to develop local strategy. They can improve early diagnosis by pointing out the value of case finding and providing education and spirometric changing. They can help with develop new commissioning models. They can suggest sequins, and there are plenty of those around the country now, local sequins around COPD, asthma, pneumonia, smoking cessation in secondary care and the like. They can suggest completely new models around diagnostic or therapeutic approaches to symptoms like breathlessness, and they can also point out that they require increased capacity in things that work, like rehabilitation. Now, I just show you an example of an area where a local stakeholder network is going really well, and this is the AHSN supported Kent, Surrey and Sussex Respiratory Network, and they are really moving along very fast. They have a fantastic newsletter which describes what they're doing, Breathing Matters there, and they're providing the respiratory community and beyond with clear ideas about what you can do for respiratory disease. It's also important to note that they have patient involvement in the network, and that's clearly up front with the newsletter there about people taking part, patients taking part, particularly taking part in commissioning decisions, and that's also mirrored in a British Lung Foundation project which is going on at the moment. So I think that if we summarize what I've said, we have to look towards the local area as the future for commissioning development. The NHS is going to develop now from the bottom up with local prioritisation. Obviously there are common standards, but these will be implemented with a local flavour. We've got to have a focus on early and accurate diagnosis and case finding, and perhaps we can use the practice informatics for that as they develop. Risk stratification within a population allows year of care commissioning, or perhaps a more rational approach to commissioning for the whole population. But this is going to be dependent upon us developing integrated care structures and hopefully vertical integration. But specialists will need to join in with this and work across the whole spectrum. But the models also require wide stakeholder involvement, particularly involving patient organisations at the heart. So thank you very much. I think this completes the talking bit of the webinar, and I'm going to take any questions that you've put in. Is that all right?
That's great. Thank you very much, Mike. I'll just share the mic with you. Good morning, everybody. It's Aileen Muir speaking for Respiratory Futures. We've had some fantastic questions through, so I'm going to field a few past Mike now. If we don't get to your question, we will put an answer up on the website this afternoon. So the first question for you, Mike, is do most service departments and specialist care and secondary care, such as radiology and so forth, have integrated IT to respond to requests and deliver results effectively?
Well, I don't know that. I mean, the IT development in the health service has not it's not been particularly good, has it? So it's clearly something that we've got to work on around about electronic patient records. And I think most trusts are encouraged now to develop all this independently and to link with GP systems. There's obviously varied development of this around the country. I don't think that relates specifically to respiratory as a problem. I think it's going to be a general development of IT.
Thanks, Mike. And the second question here, where do specialist and tertiary trusts fit into the system? Having primarily been funded by national commissioning, do you think specialist trusts need to make wholesale changes in strategy to fit in with integrated respiratory commissioning?
Well, that's for them to decide. I mean, I think that one of the influences in all this, which I haven't mentioned, is about the provider choice as to where they position themselves in the market. Highly specialized trusts obviously will receive their income primarily through the specialized commissioning process, but they are going to have to work with CCGs as a lot of these specialized commissioning items become co-commissioned. So far in respiratory medicine, most of them have remained with direct commissioning, but things may change in future. But I think this is degree of provider choice as to how much they retain their specialist identity. I don't think that NHS England is going to be directing providers or indeed commissioners as to how they should play that. It depends upon the market. That's how the structure is set up.
Thanks very much, Mike. We've just had a question through. Very good question in terms of context. Is there a time frame for implementation of the local networks?
No, as I said, these networks are not formal networks set up by NHS England. We are encouraging these, and some strategic clinical networks around the country have found some spare capacity to support them, and also academic health science networks have found some spare capacity. But the energy for setting these up has got to come from local stakeholders, from the interest of the community and the professionals and the patients. So since they're not formal structures, there's no timescale associated with them. Clearly, we would like to see stakeholder networks around the whole country. And one of the purposes of Respiratory Futures is to help support and provide good examples of where this is happening, and help people not to reinvent the wheel. So there isn't a formal timescale for these things. We would just encourage them to happen and take note of it.
Thanks again, Mike. I'm very mindful of time, but we've had some fantastic questions, and we're going to ask at least one more. This question is about the House of Care. The House of Care may be regarded as resting on shaky foundations and may need underpinning. What will provide the cement to keep it all together?
Well, the House of Care is a conceptual model, and it's very worthy, and it takes into account all the issues around individualized care and patient involvement. But you're quite right in that the transition from a conceptual model to a working commissioning structure is very difficult, and change will be difficult. But I think that's the whole purpose of the 5-year review, forward view, is that we need to experiment with commissioning structures that can incorporate the conceptual principles of the House of Care, and try and make those things work in a concrete commissioning environment. So population commissioning is one way of doing that, but there'll probably be others as well. I think the main thing is just to retain it as a conceptual model and try and make your commissioning fit as closely to that as possible.
Thanks again. One final question, which I think is a very interesting one from Guy Checkett. Where will the balance of power sit between local networks, the ones we've talked about today, and the nationally commissioned services that are the overall umbrella, at least for some of our work?
Well, Simon Stevens has indicated that the amount of direct commissioning will fall. The intention is, and the whole point, I think, of the health service reforms from Andrew Lansley was that the priorities will be determined locally. So the amount of influence that the centre has over commissioning will start to fall away. I think what the centre will do is to ensure that the standards of commissioning are high and that people stick to good standards, but the way that those are implemented locally is going to be determined locally. So the CCGs will inevitably develop even greater autonomy than they have at the moment, and in fact that's changed already as the Simon Stevens has indicated that co-commissioning of primary care will now occur, whereas when the health service reforms were initiated, primary care was retained as direct commissioning because of suspected probity issues. But all that's being thrown out, and I think that we'll find that we will eventually have a genuine federation of commissioning organisations around the country who will have a high degree of autonomy.
So do you think, as part of that process, that commissioners will perhaps better prioritise self-management, which doesn't seem to be high up the agenda right now, Mike?
Well, I think the whole focus is on trying to imbibe a greater sense of responsibility in people to take care for their own health, and that clearly involves prevention around obesity and physical activity and smoking cessation and the like, but also about making choices around their healthcare. And the evidence suggests that if people are able to make choices, they don't necessarily make expensive ones. They do improve the value of care. And so I think we have had a sort of fairly passive health service from a patient perspective over the last few decades, but we're asking people now to take much more involvement in their care along the lines that happens, for example, in America. The commissioning structure is different, but at least people are involved in their care and may make wise and economic decisions about how it progresses.
Thanks very much. So really, as a final thought, as we sign off from today's webinar, what would be the one thing that some of our listeners, if not all of our participants today, could perhaps take away? Who can we encourage within commissioning groups to better prioritise and fly the flag for self-management?
I think the sort of interesting thing about the climate we're in at the moment is that it's very dynamic, and new ideas can come forwards. So if you have a view, if you have something to say about how things can go forward, then I think now's the time to push it into the arena, because I think people are willing to consider all options at the moment. And I think it's a very exciting time for trying out new models. I mean, the encouragement to innovate at a commissioning level is growing, providing that we can demonstrate that we can do it safely and properly. The way that it's done will inevitably vary around the country. So I think if people want to try out new things, now is a great time to do it.
Thanks very much, Mike. We've had several more questions which we will post and answer on the Respiratory Futures site. But that completes today's webinar. Thanks very much for taking part and being involved. Later today, we'll upload both this presentation and the questions, and you'll be able to post further questions on respiratoryfutures.org.uk.